So we're going to continue today thinking about the heart. Last week we went over some of the general features, thought about the order of blood flow through the heart a little bit, thought some about the different circuits that we're feeding. When we left off, we were thinking about the valves, both the atrioventricular valves, as well as our semilunar valves located in the bases of our great arteries. We're going to start out with some review questions, tying together that stuff before we move on to our conduction system and the electricity in the heart that makes everything coordinated, work in order, that we're going to need to feed our heart cycle. We have a series of questions, so go ahead and join us right here. Start by remembering what part of the heart is getting blood from the outside. Yeah, so the answer is our atria. So when we're thinking about the heart, right, we've got our four-chambered structure, right? And our receiving chambers that get blood from outside the heart are our two atria. So the right atrium is getting blood from the rest of the body through the superior and inferior vena cava, which you'll see in lab next semester. When we think about the left atrium, the outside of the body outside of the heart that we're thinking about here. So we have blood coming back from the lungs. So you'll see that we actually have four pulmonary veins returning to our left atrium. They're like kind of clustered on the back. But we'll just think about it as one tube from the lungs for our purposes. Okay, so it's a vein anytime we have stuff returning to the heart. So these are all veins going into our atria. Okay. So our ventricles are always going to be getting blood from the atria. So we just move down the side if we have our pictorial depiction like this. So our right ventricle gets blood from within the heart from the right atrium. Our left ventricle, same deal. We're going to have a valve, an AV valve, an atrioventricular valve. One specifically our bicuspid or mitral valve, letting us, pass blood from the left atrium into the left ventricle. I'm kind of walking you through the steps of understanding one of the questions that you have in your packet card. Okay, so the next piece, what part of this system was keeping our blood from flowing backwards when our pumping chambers, so those ventricles, are contracting? I guess it depends where you were thinking about flowing backwards from, right? But when we're thinking about this, right, when I say backwards, what I mean is the pumping chambers are our ventricles. Right, so they're the ones on the bottom. Right. So ventricles, we got right ventricle, we got left ventricle. Okay, so the direction we want blood to flow is forward, but we're only going to be doing this when we have greater pressure in an atrium than in a ventricle, right? So in order for blood to flow in that direction, we have to have high pressure here and lower pressure here. But later on, we're going to want to send blood out the arteries, either to the lungs or out to the body, right? So let's think about the left ventricle. So when we go through the cardiac cycle, we're going to see that our ventricles contract, so they squeeze down in order to create higher pressure here in the ventricle versus lower pressure in an artery, right? So that's how we can make blood go the correct direction. But when we have high pressure in a ventricle, this would tend to force blood backwards towards the atria. We don't want that to happen, which is why we need these valves to shut. So those are our AV valves, our atrioventricular valves, and they're going to be closing in order to prevent blood from going backwards into the atria when we're squeezing down on these ventricles. Finally, if we have those ventricles contracting, which of the valves are going to need to be open? Yeah, so it's going to be our two semilunar valves. So the semilunar valves were the ones located in the arteries that come out of the ventricles, right? So the semilunar valves would be located in the aorta and in the pulmonary trunk that leads to the lungs. When we squeeze the ventricles, the whole point is to get blood out of the heart. So you're going to need to open those up so that we can get our blood going to the lungs and to the rest of the body. So we'll come back to this stuff next week when we go through the cardiac cycle. Basically, what we're going to be tracking in the cardiac cycle is what is the pressure in each of these chambers, what is the state of the valves, and therefore what direction is blood flowing. So this is just a preview of the kind of thing you're going to be thinking about. Cool. So now we're going to move into the electrical activity that coordinates the beating of your heart muscle before we move forward into the blood itself. Okay. So we're going to start by understanding how these electrical properties develop and what they're doing. So we remember that one of the features of cardiac muscle, like some of our types of smooth muscle, is that we have the ability to develop pace of electrical activity without external input. So you don't need nerves coming in, you don't need anything. If you put some of these cells in a petri dish, they're just going to kind of pulse with electricity. So heart cells have this property of autorhythmicity, so an automatic rhythm to them, right? And that's really all that's driving our heartbeat is connections between the cells, but really just the fact that these cells, the way they work is they just kind of pulse, right? They're not even the only cells that do that. But in the heart, we're specifically going to have two types of kind of autorhythmic cells that are involved in making sure that we have the right pace to that beating and that we're coordinating all the correct parts of the heart, because we're going to want things to contract in the right order, to contract kind of all at once, you have scattered pieces of your heart muscle beating kind of at random, that's not going to move your blood appropriately. You're going to have a heart attack, basically. So we're going to have two types of cells we're interested in. We're going to be thinking about our pacemaker cells. We're going to be thinking about our conduction fibers. So these are kind of separate from the cardiac muscle cells themselves, right? So these have unique properties. So the pacemaker cells are going to be spontaneously depolarizing. So basically what we mean, we have resting membrane potential that just kind of automatically changes at a certain rhythm, creates these waves of depolarization kind of automatically. So their job is going to be to coordinate the heartbeat and provide the rhythm. The conduction fibers are going to be specialized for rapidly moving action potentials from our pacemaker cells and out to all the other contractile cells of the heart. Right, so the myocardium, the heart muscle, made up of cardiac muscle cells, they're going to do the contracting. They're the ones with like the sarcomeres and stuff to get smaller. So within each of these groups, we have a couple different types. So we're going to have a sinoatrial node in the right atrium. This is really what we think of as the main pacemaker of the heart. We're going to have an atrioventricular node, kind of at the junction between the atria and the ventricle. And we have a couple of different types of conduction fibers. We're going to have internodal pathways that move between the nodes. We're going to have something called the bundle of His. Then we're going to have some Purkinje fibers, and we'll take a look at each of these. But before we do that, since we're about to talk about speeds, so if the sinoatrial node is firing 80 action potentials per minute, the atrioventricular node is firing 60 action potentials per minute, and a Purkinje fiber is firing 20 action potentials per minute. What do you think is going to be controlling the overall heartbeat here? Which of these numbers is going to match like how many heartbeats you take? Yeah, so the SA node is our most important collection, specifically of pacemaker cells. The reason is because it's fastest, right? So when we're thinking about these action potentials, right, we're thinking about pulses, right? The SA node is going fastest. So while we have waves of depolarization coming from these other types of fibers, kind of baseline, if you isolate them in a petri dish, the fastest one is just going to hijack that rhythm. It's going to interrupt that. And then everything's going to kind of depolarize with whatever is moving fastest, which should be the SA node. So the SA node fires at a variable, but between 70 to 80 action potentials per minute. Our other collection of pacemaker cells beats a little bit slower. So if something messed up your SA node, that doesn't mean your heart wouldn't beat at all necessarily. We can have some of these other rhythms take over if the SA node were to fail. We get quite slow if you had to rely on just the conduction fibers, though. Okay. So the reason the SA node is able to take over is because all this stuff is connected. So everything's connected up by gap junctions. Particularly, we have a lot of gap junctions if we look at intercalated discs connecting together different fibers. But we got a lot of gap junctions, meaning our cytoplasm of one cell touching the cytoplasm of the next cell. So when we have a depolarization in one cell, it just goes through to the next one and kind of affecting each other. Fastest one is going to be in charge of the whole heartbeat. If you think about how the heart beats overall, we're starting with heat with these cells with their depolarization, and then we're sending them through gap junctions to the rest of the cells of the heart. So down the conduction fibers, and then from the conduction fibers out to the muscle surrounding. So the order we want things to happen when we're contracting. So we got our heart, we have our four parts. We're basically going to have the top and bottom halves of the heart kind of going as two pieces like that, atria together, ventricles together. So our right atrium and our left atrium up top, you're going to want them to contract first because they've been receiving blood from the outside, right? So we just set right atrium was receiving blood from the rest of the body through the two parts of the vena cava. The left atrium is receiving oxygenated blood from the lungs. Okay, so it's just kind of pooling in there. So we want them to contract a little first because when they contract, they're going to send blood down into the ventricles. And then we're going to want the ventricles to contract so that we can send blood out to the lungs from the right side to the rest of the body from the left side. So we need our conduction pathways to make sure that from our sinal atrial node, the SA node, that fastest one, we're passing in that direction. So we're going to see that when we think about the conductivity of the heart, basically, we're going from that SA node in the right atrium down through our atria, and we're going to go down through this septum, so this wall between the true ventricles. And at some point in there, we're going to split apart into two bundles and then wrap around and up. And the reason for that is we kind of want to be squeezing sort of from the bottom up so that we can get into the large blood vessels that are kind of going up and out if you look at a real heart. Slightly easier to draw a diagram. Okay. So when we have those gap junctions, a lot of them are located in the intercalated discs, which link together the contractile cells of the heart. And in addition to having gap junctions, so that these action potentials spread, they also have another type of junction called a desmosome that's really important. So those are like, think of them as like scaffolding. They're physically holding the cells together so that we can kind of resist the force that's happening as these cells contract. So they're kind of keeping your heart from stretching out too much as we have these kind of forces moving through. So here we can see what those kind of look like. So here we see a connection between the SA node, and we can see some of the muscle cells coming out of it here. Right? Just in general, we're zooming in on an intercalated disc. Right? So here's our zoomed in intercalated disc. So you can see that we have sarcomeres. Right? So cardiac muscle is striated muscle, so it's stripy. It's got these sarcomeres that look like our other sarcomeres did. Here's that gap junction, so just acting as a tube between these cells. And here we see those desmosomes, which are like a physical structural junction tying these together, keeping them from pulling apart or stretching too much. We're passing going in order. So our action potential for the heart as a whole is going to start in that SA node in the right atrium. And that signal is going to be passing through the atria, through the muscle, through interatrial pathways, right? So when I drew, okay, so SA node, then we're going through muscle, through interatrial pathways, here we go, through an internodal pathway to our AV node. There's a little bit of a delay here. So we got like a little pause, which is great because we want that blood to be moving kind of from the atria to the ventricles during this little bit of time. Okay. So we got a little bit of delay. And then we have an atrioventricular bundle. Okay, so there's going to be a bundle, the bundle of His, where everything is together for a little bit, the bundle of His, and then we split out into right and left branches before we swirl back up as our Purkinje fibers. That is the order that we're going to have these things go through. So we're going to look at them in a better drawing than mine. Okay. So here we see that SA node up top. So right here, where we have our superior vena cava, bringing blood from the body into our right atrium. So we got our electricity starting right there. Here we see our internodal pathways leading us to that AV node. Okay. So now we're going to our AV node. We can see that between these two, we did have some of that action potential spreading out between both of our atria, right? So we've contracted this muscle up top kind of generally. Then from that AV node, we travel together for a little bit. So that's our bundle of His, is where we have all our conduction fibers running together for a second before they split into a branch along the right ventricle and a branch along the left ventricle. And then we swirl around with our Purkinje fibers. You can see those Purkinje fibers also heading into the myocardium. So you can see those little kind of tendrils, making sure that we are innervating. Maybe let's not think about nerves yet. Okay. We're getting our action potentials, let's say, to our myocardium here, starting from the bottom. So as we squeeze up, right here, you can see why it's important that we're squeezing from the bottom to the top, right? Because our aorta coming out of that left ventricle is actually coming out of the top of the ventricle, and our pulmonary trunk is kind of behind. It would be coming out kind of towards us a little bit. So you can't see it on here. So when you look at the anatomy of the heart in lab, it's going to be a little bit complicated to first kind of get your mind around which direction is which direction compared to a picture. But this is the basic process of how it works. Our autorhythmic cells have these potentials, these automatic membrane depolarizations, and we can look at why and how those are happening. So what we want to remember that we know about ions, we're really just going to be tracing our same old ions that we've been thinking about throughout this course. And so we know the directions of those ions, right? So we know that potassium ions want to go out of cells. Remember, sodium ions, calcium ions, both want to come into cells. Here. So when we think about depolarization, we're thinking of a combination of positive charges flowing in. And if we think about returning to a rest stage, we're going to be thinking about potassium flowing out. So when we think about the permeability changes on these next couple slides, because stuff is opening and closing, this is what we're really just trying to think about. Do we have positive charges coming in, causing depolarization? Are we blocking movement of potassium, or are we letting it out? Okay. So when we're thinking about those pacemakers, what we're going to see happen is that we're going to have these spontaneous depolarizations happen as we close potassium channels. So we're not losing positive charges. And we have sodium and calcium being allowed in specific orders, right? So we're going to see that sodium kind of starts stuff off a little bit, but calcium is going to play a bigger role than it did when we were talking about like nerves. So calcium is going to allow for further depolarization beyond an initial little change due to sodium. Okay. So we're going to, like in our nerve, depolarize to a threshold. We're going to open up a bunch of fast calcium channels in the heart in these pacemaker cells, whereas in our neurons, it was sodium channels. But this is working the same way. We have this rapid depolarization, which is an action potential, just a new, different kind. And then we're going to repolarize by allowing positive charges to flow out of the cell. So that's going to have to be potassium because of the direction of our gradients that we've set up around the cell. So here's what that looks like. So a reminder, these are pacemaker cells specifically. I think it says it tiny in the bottom. But I'm pointing this out because we're going to be thinking about what's happening in the contractile cells in a second, which is going to be a little different. Okay. So what we're looking at first, and so this first little bit is a slow depolarization where the P is permeability on these, right? So P equals permeability. That's enough room. Okay, so the permeability of potassium is decreasing. So we're blocking potassium from leaving, and we're increasing the permeability to sodium, meaning we're letting sodium in. But that only gets us so far, right? So what happens next is we have a little bit of time where we're starting to see that permeability to sodium fall back down again, but calcium is going to start taking over. So we're going to change the permeability to calcium. So that's going to take over from sodium. So we're still depolarizing. And then we're going to have a rapid depolarization here. So this rapid depolarization phase, creating this peak of this action potential, is all due to this calcium. So lots and lots of calcium is flooding the cell during this rapid depolarization, this action potential of a pacemaker cell. This is what we're thinking about happening like in the SA node. Which means that in order to repolarize, we're going to have to block calcium. So that's this part where we have our permeability of calcium decreasing. So we no longer have calcium flooding into the cell. And we're going down because we're letting potassium flow out. So that's what's happening as we repolarize here. So some similarities, some differences from what was going on in our nervous tissue. We got kind of like a mix between how neurons work and then how our muscle cells work, right? Because calcium was really important for our muscle cells. So that was the pacemaker cells. Now we're thinking about the contractile cells. So the ones that are actually physically shortening, physically contracting, sarcomeres, that kind of stuff. So again, we're going to be thinking about sodium and calcium, both of which want to come in, potassium, which wants to leave. We're going to be changing the permeability to these ions. In this case, we have numbered phases. You don't typically number the phases of the pacemaker cells. They're just kind of doing their thing. But we do think about numbered phases for our cardiac contractile cells. So we're going to start out by increasing our permeability to sodium. We're going to let sodium come into the cell, just like our other types of cells. And we're going to slow down that permeability to sodium, not let sodium move so much in phase one. In phase two, we're going to start to see calcium take over. So in this case versus our pacemaker cell, there was a bit of a pause, right? So we're increasing our permeability to calcium, calcium coming into the cell. And at this point, we're blocking our potassium. So in our pacemaker cell, we started blocking potassium at the beginning. Now blocking potassium takes it a little time to happening in this kind of middle phase of phase two. And then phase three and phase four, as we're going back to rest, we're going to allow potassium to leave the cell and turn off that calcium signal, stop letting calcium flood into the cell. So So this action potential that we're creating in a contractile cell of the heart, it's relatively long in its duration. So in skeletal muscle, it's probably a couple milliseconds. Longer in a heart cell if we're generalizing. Okay, and let's do a little bit. So this is what the graph looks like for those phases that we just talked about. So we can see here that we almost have a straight line up for our depolarization, right? So sodium is creating this big depolarization in a contractile cell, just like it did in a neuron, right? So the pacemaker cells, where we have calcium creating the big depolarization, the contractile cells, we're back to that big role for sodium. Okay. So here we see that kind of pause bit, right? So here we can see that signal from sodium turning off in phase one. Here we see calcium kind of taking over a little bit, creating a bit of a pause, but not shooting us back up here. Right? So calcium plays a role, but it's a different role than it was in a pacemaker cell. And then finally, when calcium stops kind of holding the line here, we see repolarization as potassium leaves. And then at rest, we're just at rest, stabilizing everything, waiting for our next action potential to come through gap junction and kind of trigger all these events. So next, in order to actually contract the cell, we've got an action potential, right? That's our signal, but we need to actually contract sarcomeres for our heart to beat. So we got to couple that electrical activity, that depolarization, to actual muscle contraction. This is going to look very similar to skeletal muscle. So the big difference is that some of our calcium is going to be external rather than having all of it coming from the sarcoplasmic reticulum. So hopefully this will look pretty much the same as we walk through it. All right, so just like in our skeletal muscle, we're going to see that we have T-tubules. So those are those tunnels down into the cell where we see our action potentials travel. We're going to see a sarcoplasmic reticulum that contains calcium in those lateral sacs of the sarcoplasmic reticulum in our skeletal muscle. Kind of same deal here in a cardiac muscle cell. And we are going to see that we have a pretty normal looking sarcomere, right? Myosin, actin, and that actin has tropomyosin lying over it, controlled by troponin, to receive that calcium signal and start all our cross-bridge cycling. So that's all going to look the same. The difference is that our signal is coming to us, our action potential is coming to us through a gap junction, and we have a role for calcium that comes from outside the cell, rather than all our calcium coming from inside those lateral sacs of sarcoplasmic reticulum. Okay, so I'll walk through this step by step. And so what we're looking at here are two cells, two heart cells next to each other. Could be two contractile cells, could be an autorhythmic cell and a contractile cell. So cell one, cell two. Okay. So we're going to start with an action potential in this first cell. Right. So our action potential would be here. Okay. And we want to rapidly spread this to the next cell so that we have our heart cells kind of working together. So that current is going to go straight through into our next cell. So that depolarization going through the gap junction. So here we see the T-tubules next, right? So here is our T-tubule in green. So our tunnel up and down, and that's going to be involved in our next step, which is that we have our action potential here, right? So some of this action potential is coming down into the cell along the T-tubule. Some of it is traveling up and out and around to the plasma membrane, right? So we've got this direction and we've got this direction. We're basically depolarizing the whole cell. Now, if we're going along the plasma membrane, we might go down another T-tubule somewhere else. There's not just one T-tubule in a cell, there are multiple. So step 3 is that we're getting our calcium, right? So we want the calcium because that's what triggers cross-bridge cycling. That's what causes the actual contracting of the cell. Okay. So we can see that that calcium is coming from 2 places. Okay. So we have some of the calcium coming from, so some of that calcium is coming from the outside of the cell, right? So here we can see a calcium channel in the plasma membrane. Some of it is going to be coming from sarcoplasmic reticulum, just like we saw in our skeletal muscle. So we're opening channels here as well. Our end result is that we've got calcium hanging out in our cytoplasm. So then things are going to work exactly the same as they did in skeletal muscle. So once we have calcium present, calcium binds to troponin, that little regulator molecule, that little snowman that was sitting on our tropomyosin on the actin. Once we bind to the troponin, that pushes the tropomyosin off our myosin binding sites on the actin, which means that actin and myosin can now grab onto each other. As they grab onto each other, right, that's the whole thing about the cross-bridge cycle. That's how contraction works. And so we have the myosin grab to the actin, push it towards the center of the sarcomere. This is how our cell gets shorter. That's what contraction is. So our cross-bridge cycling happens in our contractile cell. And then in order to relax, we got to get rid of the calcium. So it goes back to where it came from. So some of the calcium is going back into the sarcoplasmic reticulum, and some of it is getting pumped out of the cell into the extracellular fluid. So in order to relax our heart muscle, what you do want to do, you have a totally contracted heart at all times. It would not fill with blood. You would not have a heartbeat. You wouldn't die. So we want to relax that cardiac muscle. We're removing the calcium from the cytosol, sending some of it out to the extracellular fluid. We do that because we have a transporter present in the plasma membrane. We also have a transporter in the sarcoplasmic reticulum, which is why we can suck calcium back into that structure. We also have a sodium and calcium exchanger in the plasma membrane. So that's kind of involved in this pumping calcium out. When we get rid of the calcium, everything goes back to normal. Our troponin goes back to its normal state. So our tropomyosin covers our binding sites again. No more cross-bridge cycling. Summing this up, I want to remember what type of autorhythmic cells we have. Okay, so which were the type that were coordinating and providing this rhythm to the heartbeat? Good. Cool. Perfect. Yeah, our pacemaker cells and our conduction fibers, the main part of what we were talking about here with our electrical pathways. So we're producing this rhythm and then spreading it out. Our contractile fibers then contract. Perfect. So the pacemaker cells, remember their name. What types did we have? Okay, great. So we had our AE node and our SA node. A node, the one that should be in charge of everything, the fastest one, controlling the heartbeat, but we've got the AV node kind of as backup, and creating a kind of nodal delay between the atria and the ventricles. And it all gets everything working together. So I know I'm going kind of fast today. So backing up as we're thinking about this unit and the end of the class, part of why I'm going fast is because this should be lower priority for you than like learning all the phases of an action potential was when we talk about nerves, or learning all the pieces of exactly how the muscle cells work in the last unit and the main muscle unit. So our big kind of topics that I want you to make sure you understand and spend most of your time with. Do remember that muscle physiology that we've been covering, but then our next piece that's going to be really important is basically blood flow through the heart and how that works up with pressure and what it's contracting when. So this is stuff that I want you to be aware it exists and know some of those similarities and differences to topics that we've talked about previously, but don't kill yourself over this concept. That's the big picture here. We're focusing on big picture. And you can come back to this if you end up a heart specialist. Okay. So we're now going to focus on how we would study the heart if you're looking at a patient, right, trying to figure out stuff about it. So you can record electrical activity generally from electrodes on the skin. So you've done that somewhere, muscle contraction, but you can also record the heart rhythm. Right, so we can have heart monitors, which is great. This is a non-invasive way of figuring out what is going on in the heart if we're trying to diagnose an issue. We have to get a little creative as we're reading those results. We can tie them to these events that we see in the heart, but we're not going to directly record an action potential with the exact flow of ions from electrodes on the skin. So an electrocardiogram, so an EKG or ECG, same thing, just sometimes in biology, they used to do a bunch of it in German, so C's sometimes get replaced with K's, same thing. An electrocardiogram is a measurement of the electrical activity of the heart, using the body as a conductor so that we can interpret what's going on in different parts of the heart. So the placement of electrodes would be important to make sure that you're triangulating the signal appropriately. So currents in the body can spread across the surface of the body. There are other types of techniques of looking at the body, other parts of the body that we record in the same way. So you can record muscle contractions, you can record brain waves, also using electrodes. So ECGs, EMGs, EEGs, all of those use this general principle of body conducting electrical activity from the inside. So we're going to be thinking when we're looking at these, you're going to see some of these signals are going to be stronger than others. So we're going to be looking at a very typical kind of wave pattern. So that's going to depend on the size of membrane potentials that are being created, as well as from the synchronicity with other cells. So like how many of the cells are doing the same thing at once. Electrical activity in the heart is highly synchronized. So what you're looking at when you're looking at an ECG is going to look like this lower image. So our electrocardiogram is on the bottom. So you'll see these, right? So we have first a little bump, your P wave. And then we have a dip down to Q, a peak up to R, another dip down to S, and then we come back up and have a final peak with the T, and a long pause and repeat again. Okay, so we refer to that typical structure, right? This is our PQRST complex. And by looking at the time it takes between different segments, right? So from here to here, here to there, etc. How long each of those peaks and kind of rest periods take, we can interpret what's going on inside the heart. So you can see that this is different than what's happening to the membrane potential of our contractile cells, right? So here we see, and so this is the big spike of sodium in a contractile cell. Here we see sodium turning off, that little plateau as calcium takes over slightly. And then no more calcium coming in, lots of potassium leaving. That was what our electrical activity of a single contractile cell looked like. So we're not seeing that with our electrodes. So we got to interpret this stuff. Okay. So what's happening here? And we will talk about this and pair it up to our cardiac cycle as we go through the cardiac cycle in our next section, which is one of the things I really do want you to focus on and make sure you know all the pieces of. So this is a kind of preview. So what we're looking at first with this P wave, right? So that P wave, that's the atria of the heart depolarizing, right? So the P part, first we're noting that depolarization up top. So our atria depolarize first because we want to be squeezing blood from the atria down into the ventricles. So our P wave happening here. The QRS complex we usually look at as a unit, right? So what we're looking at is this dip down, spike up, dip back down. Okay. And what's happening there is that after the P wave, right, you have to repolarize the atria. So they go back to normal, right? And the ventricles have to depolarize. So that section where we're kind of setting the atria back to normal, and then we have our big depolarization happening in the ventricles. You can think of that as like the R, that depolarization, right? And then either side, we have that repolarization of the atria coming through, which is why we can see it kind of lower down than normal for that Q and S on either side. So this is where we have those ventricles contracting, basically. So that's your ventricle squeezing blood out to the lungs of the body, but we're usually focused on the left ventricle squeezing blood out to your systemic circuit. Our T wave represents ventricular repolarization. And then our PQ segment, we can look at different segments. So this is our nodal delay, so how much time there was between when our atria and then our ventricles start contracting. And overall, we are going to divide this kind of in half, but we have to loop around. So we're going to be thinking about heart squeezing is systole, heart relaxing is diastole. Right, so when you look at blood pressure and you have numbers, two numbers on there, you have a systolic pressure. That's where when the heart has just been squeezing blood out to the body. You have a diastolic pressure. So like when the heart is relaxed and not squeezing. And so squeezing is systole, and specifically we're thinking about ventricles. So that's happening between Q and T. Okay. And then between T and Q of the next one, that's when we have diastole. So you can see that the relaxed part of the heart cycle should be the longer part. So the heart squeezes rapidly and then has a longer phase of relaxation. Oh, sorry, I didn't realize I was a minute over. All right, good place to end. Sorry, guys. See you on Friday. Link that up to our cardiac cycle.